the conservative management will be helpful in these patients. So these are the various characteristics. If the patient is young, surgical AVR, higher age, there is TAVR will be preferable, and previous cardiac surgery TAVR will be having edge over surgical AVR. Active or suspected endocarditis, again surgical AVR, and thrombus in aorta. These factors favor the surgical AVR. And if the patient had significant multivessel CAD requiring surgical revascularization, this TAVR is the only option. And sometimes if the lesions are very focal, you can do PCI and TAVR. And severe primary mitral valve disease, tricuspid valve disease, and septal hypertrophy requiring myomectomy, these are the patients who are slightly favorable towards surgical AVR. So I have diagnosed the severe aortic stenosis. What are the guideline recommendations? If the patient had severe aortic stenosis, that is valve velocity more than 4 meters per second and gradient is more than 40 millimeters of mercury, intervention is required. Whether it is SAVR or TAVR, based on the other risk factors, other comorbidities we need to decide. And intervention is recommended even in symptomatic patients with severe low flow, low gradient aortic stenosis with ejection fraction less than 50%, but the gradient is less than 40%, and aortic valve area is less than 1. And even if the patient had low flow, low gradient AS with normal ejection fraction, and if the patient is symptomatic, it is a class 2A recommendation. And even in the patient with symptomatic aortic stenosis with low flow, low gradient with reduced ejection fraction, and if other factors are not deciding, then with the coronary CT calciums of the aortic wall, if it is more than 3000 in men as per ESC, and if it is more than 2000 in men as per ACC, it is an indication for AVR, whether it may be surgical or TAVR. It's a class 2A recommendation. If the patient had severe comorbidities and if their life expectancy is less than 1 year, it is a class 3 recommendation not to do any procedure in this. Suppose if the patient is asymptomatic, if the patient had LV dysfunction, that is ejection fraction less than 50%, again it's a class 1 recommendation. Even in asymptomatic patients, very severe AS and with demonstrable symptoms on exercise testing, that is fall in blood pressure more than 20 millimeters on exercise testing, it's a class 2A recommendation for this patient. And exercise testing symptoms are there, again it is a patient having symptoms on exercise testing, it is a class 1 recommendation for it. And very severe AS asymptomatic, it's a class 2A recommendation. And severe valve calcification and rapid progression of the symptoms or rapid progression of the velocity, that is more than 0.3 meters per second per year, it is an again class 2A recommendation. And markedly elevated blood brain BNP, it is more than 3 times age and sex related normal range on multiple occasions and repeated measurements without any other explanation. This is an again class 2A recommendation. So you have decided the patient requires some intervention, whether it is a SAVR or TAVR. We need to again assess the patient.